A 69-year-old man sits in an examination room. He has been waiting 3 weeks for this appointment. He has 4 things he needs to discuss. He has been thinking about them since he booked the visit. The doctor walks in, reviews the chart, asks a few standard questions, adjusts one medication, and is back at the door in 9 minutes. The man drives home with 3 of his 4 concerns completely unaddressed. One of them, a recurring dizziness he has been experiencing every morning when he stands up, he decided not to mention because the appointment felt like it was already over. 2 months later, that dizziness becomes a fall. The fall becomes a fractured hip. The fractured hip becomes a 6-week hospitalization. The information that could have changed that outcome was in the room. It never left his mouth. This video is about making sure that never happens to you. I am Dr. Hameed Ullah Shaheen, and today I want to address something that affects the quality of your medical care more than almost any clinical factor, and that almost nobody talks about directly. It is not your diagnosis. It is not your medication. It is what happens, and what fails to happen, in the 15 minutes you spend with your doctor. Because here is the reality of modern medical appointments. They are short, they are structured around the physician's workflow rather than the patient's concerns, and the burden of making them useful falls far more heavily on you than anyone will admit. That is not an indictment of doctors. Most physicians are working as hard as they can within a system that gives them inadequate time with every patient. But understanding the structural problems in that system and knowing exactly what to say to work within them is the difference between an appointment that protects your health and one that leaves the most important things unsaid. I am going to walk you through 6 specific situations that arise in medical appointments for adults over 60, why each one is genuinely dangerous, and the exact words you can use to address them, without confrontation, without burning your relationship with your provider, and without feeling like you are being difficult. Because you are not being difficult. You are being a patient, and patients have the right to be heard. Situation 1. You are rushed before you have finished speaking. Research published in medical communication journals has documented something that should concern every patient. On average, physicians interrupt or redirect patients within approximately 20 seconds of them beginning to describe their symptoms. 20 seconds. In that moment, the clinical narrative gets reorganized around the doctor's early hypothesis rather than the patient's full picture. And everything the patient was about to say next, the second symptom, the qualifying detail, the context that changes the interpretation entirely, gets filtered through that premature conclusion rather than heard on its own terms. In adults over 65, this is particularly dangerous because symptom presentations are frequently atypical. The way a cardiac problem presents in a 70-year-old woman is often genuinely different from the textbook presentation a physician was trained on. The nuance matters. The full picture matters. And if the full picture is never completed, the clinical decision is made on incomplete information. Here is what you say when you have been interrupted before you have finished. I understand that, and I need to finish describing the rest of what I have been experiencing so you have the complete picture. The phrase complete picture is deliberate. It frames your remaining information not as disagreement with a doctor's early assessment, but as a clinical contribution to their decision-making. You are helping them. That framing matters. Do not argue with their early conclusion. Let them finish their thought. Then use that phrase and complete your description. Situation 2. You can feel the appointment ending before it should. Every experienced patient knows this feeling. It arrives without a single word being spoken. The doctor's posture changes slightly. The typing slows or stops. There is a subtle shift in energy in the room. A gathering. A preparation for conclusion. Even though you still have things you came to say. In medical communication research, this is sometimes expressed through what clinicians call closing behaviors. Non-verbal and verbal signals that communicate finality before the patient has confirmed they are finished. A hand moving toward the door. A summary statement offered before all concerns have been addressed. A slightly raised pace of speech. For patients over 60 who have been socialized to defer in professional settings, to not take too long, to not be a burden, these signals work. They produce exactly the result they communicate. The patient wraps up. The unspoken concern stays unspoken. The appointment ends. Here is what you do. And I want you to notice that this does not require raising your voice or creating conflict. Before the appointment even begins, when the doctor first sits down or enters the room, you say this: I have 3 specific concerns I need to address today. Can I tell you what they are up front so we can make sure we cover all of them? That single sentence does several things simultaneously. It establishes the agenda for the visit before the physician sets their own. It signals that you came prepared. It creates an implicit commitment from the physician to address all 3. And it protects you from the closing behavior arriving before you have reached concern number 2. Write your concerns down before you go. On paper, not a phone note. Paper that you hold in your hand in the room. The physical act of holding a written list communicates preparation in a way that changes how the interaction unfolds. Situation 3. A new prescription is written without a full review of what you already take. This is the situation with the most direct connection to preventable hospitalizations in adults over 60. And it is one of the most common failures in rushed medical appointments. When a physician is working against time and identifies a change that needs to be made to your treatment, a new medication, an adjusted dose, a substitution, the path of least resistance is to make the change, write the prescription, and move to the next patient. What that path does not reliably include, in a 9-minute appointment, is a careful and complete review of how that change interacts with every other medication, supplement, and herbal preparation you are currently taking. The clinical term is polypharmacy, the management of multiple medications simultaneously, and in adults over 60, it is one of the leading contributors to emergency room presentations in this country. Not because the medications are wrong individually, because their interactions in combination are not being reviewed carefully enough at the point of prescription. The dangerous part is that many of these interactions are not obvious. They are not on the label. They do not appear in the brief summary a physician calls up in a 9-minute appointment. They require deliberate, unhurried attention to your complete medication list, including things you buy over the counter, including supplements, including anything you take occasionally. Before you leave your chair after any prescription change, ask this: before I start this, can you walk me through how it interacts with my complete current list, including everything I take, not just my prescription medications? And hand them your list. A written list, carried to every appointment, of every prescription medication, every over-the-counter medication, every supplement, every vitamin, with the exact dose and timing for each. If the physician cannot answer the interaction question fully in the room, that is information you need. Ask whether a pharmacist review of your complete medication list would be appropriate. Many hospital systems and community pharmacies offer this as a service. It can catch what a rushed appointment misses. Situation 4. Your symptom is normalized as aging before it is investigated. There is a phrase that more adults over 60 have heard in medical appointments than perhaps any other. Some version of, "At your age, that is fairly normal." Sometimes this is accurate and genuinely reassuring. Certain changes are expected features of aging physiology, and a physician who explains that clearly is doing their job well. But sometimes, and this is the situation I want to address, symptoms that have a specific, identifiable, treatable cause are being attributed to age because the appointment is too short for a more thorough investigation. Because the history taking was insufficient. Because the symptom was mentioned briefly and moved past rather than followed. Fatigue that has changed in character over the past 3 months. Dizziness when standing up that has become more frequent. A sleep pattern that has shifted in a way that feels different from normal. Cognitive fogginess in the afternoon that was not there a year ago. These are not automatically the price of aging. In many cases, they are symptoms with clinical explanations, medication side effects, thyroid changes, blood pressure management issues, early markers of conditions that respond well to early identification. If you are told that a symptom is probably age-related, you have the right to ask, what would we need to rule out before concluding it is related to age? And what test or assessment would do that? That question does not challenge the physician's expertise. It invites them to think one step further, to identify what investigation would confirm or rule out a clinical cause before attributing the symptom to aging. In many cases, they will order a test they might not have considered in the momentum of a short appointment. In some cases, that test will find something. The retired teacher who is told her afternoon fatigue is age-related when it is actually a diastolic blood pressure that has been pushed too low. The grandfather whose morning unsteadiness is attributed to getting older when it is orthostatic hypotension caused by his antihypertensive medication. These patients needed someone to ask that question. You are that someone. Situation 5. You leave without understanding what happens next. A well-conducted medical appointment ends with clarity. Before the physician leaves the room, you know what was decided and why. You know what tests are being ordered and what results would change your management. You know whether anything in your medication has changed, exactly how and exactly when. You know when you are expected to follow up and what would make that follow-up more urgent. That kind of closing takes approximately 3 minutes. In a rushed appointment, it does not happen. What happens instead is that the physician exits, a nurse or receptionist hands you a printout at checkout, and you walk to your car holding a document that answers perhaps half of what you needed to know. The rest you reconstruct from memory during the drive home, which is when most people realize they are not entirely sure what they were told. At home, the errors begin. The new medication is taken at the wrong time. The old medication is continued when it should have been stopped. The follow-up scan is not scheduled because its urgency was never clearly communicated. The symptom that should trigger an earlier return visit is not recognized as such because nobody specified what to watch for. These are not failures of memory or intelligence. They are failures of communication that occurred in the examination room and then play out, sometimes seriously, in the days and weeks that follow. Before the physician leaves, before they are fully at the door, you say, "Before you go, let me read back what I understand we decided today so we can confirm I have it right." Then read it back. What is stopping? What is starting? What is being ordered? What you are watching for? When you are coming back, and under what circumstances you would come back sooner. If anything you say is incorrect, it is corrected right there, in the room, with the physician present, rather than at the pharmacy counter or the medicine cabinet at 11 o'clock at night. This technique is called teach back, and it is one of the most evidence-supported patient safety tools in clinical medicine. Most physicians know it. Most physicians, under time pressure, do not use it. You can use it yourself. You do not need to wait for them to initiate it. Situation 6. You feel you cannot ask about something because it seems too small. This is the quietest and perhaps the most consequential situation on this list. Because the information that most frequently goes unshared in a medical appointment is not the dramatic symptom, it is the small one. The thing the patient has been sitting with for weeks, wondering whether it is worth mentioning. The detail that feels minor. The question that feels foolish. A brief visual disturbance that passed in 2 minutes. An irregular heartbeat that lasted 30 seconds during prayer and then resolved. A new pain in an unfamiliar location that only appears occasionally. A medication that has been causing a side effect the patient has been tolerating because they assumed it was simply how the medication works. In cardiovascular medicine specifically, the symptom that a patient hesitates to mention because it seems too brief or too vague is sometimes the most clinically significant piece of information in the room. Transient symptoms are not minor symptoms. They are the language the body uses before something becomes persistent. If you are holding something back because you are not sure it is worth the physician's time, say this: I have one more thing I want to mention. I'm not sure if it is relevant, but I would rather have it in my chart. That framing is perfect. It does not overstate the symptom. It does not demand an answer. It simply ensures the information is documented, and documentation changes everything. A symptom in the chart can be connected to subsequent findings. A symptom that was never mentioned cannot be. The phrase "I would rather have it in my chart" is one of the most powerful sentences a patient can use in a medical appointment. It frames the disclosure as a collaborative, professional act rather than a complaint. And it creates a record that protects you. The protocol: what to do before every appointment. Let me give you something concrete and simple that you can implement before your next visit, whether that is next week or next month. The night before any medical appointment, do 3 things. Write down your top 3 concerns in order of importance. Not a list of 10. 3, prioritized, in your own words, on paper. Update your medication list. Every prescription, every over-the-counter item, every supplement, dose and timing for each. Carry a copy to every appointment. Write down one symptom you have been hesitant to mention, the one that feels too small, too vague, too uncertain. Commit to saying it in the appointment, using the phrase, "I am not sure if it is relevant, but I would rather have it in my chart." Those 3 preparations take 15 minutes the night before. They can change the quality of every appointment you attend for the rest of your life. The man I described at the beginning of this video, the one who drove home with 3 of his 4 concerns unaddressed, was not passive because he was careless. He was passive because nobody had ever given him the tools to be otherwise. The medical system he was navigating was not designed around his needs. It was designed around throughput, documentation, and the management of time that is structurally insufficient for the conversations that actually protect people's health. You cannot change the system, but you can change what you do inside it. The 6 phrases I have given you today are not confrontational. They are not demanding. They are the language of an informed, engaged patient. And in my experience, clinical teams respond to that language better than to either silence or frustration. Because it gives them specific, actionable information. Because it makes their job easier. Because it produces better outcomes for everyone in the room. You deserve to leave every medical appointment knowing that everything important was said, heard, documented, and understood. Those 6 phrases are how you make that happen. Share this video with someone in your family who you know holds back in medical appointments. The spouse who does not want to bother the doctor. The parent whose appointments always seem to end before they are ready. The friend who comes home from every visit with questions they forgot to ask. They need these tools, and you are the one who can make sure they have them. Leave a comment below. Tell me which of these 6 situations you have experienced most. I read every comment. I am Dr. Hameed Ullah Shaheen. Your appointment is your time. Use all of it.